limits little bit of the movement. But the main point which limits the movement is inflammation. In 2004, 2006, and 2007, and 2012. The patient opened very well. And if you look the condylia, it looks better. When we rehabilitate functions, you can have a good impact on the bone remodeling. Even it is not a young person. The last question that I would like to discuss with you, perhaps you have questions for this part. We can have a small discussion now. No question. Okay. You are waiting the answer to this question. Huh? And so, what is the incidence of occlusion on therapeutic decision? The academic way is currently in TMD patient never touch the teeth, never touch occlusion. The incidence of malocclusion to the TMD is very, very low. So don't touch the teeth. It is globally true because generally we can decrease the pain of muscles or joint pain and increase the function only by non-invasive treatment. Generally. But I have two remarks. First remark is I would like to underline the difference between invasive treatment and over treatment. And after, I would like to define what is obvious occlusal disorders. This patient is here in ICP and here in RCP. If you look the situation, the transverse situation on ICP, and in centric in RCP, they are not clearly an important transverse shift. Very good question. I come back soon on this question, on these questions. Okay, no transversal shift, not really, but there are an important vertical difference between ICP and RCP. We have a pre-palatality here, and the patient to close in ICP go forward like this. Here it is in ICP. And look at this teeth. With a very big restoration and strong wear facet. Yeah, you can see the retrusive guidance. So this patient can have pain or not. My hypothesis, this patient has pain on his muscles. Okay. May I may I I have to build to realize a splint. To realize splint, I must take impression, centric records, mount to the cast on the articulator. In this case, it is difficult to make centric records because for the centric records, I don't want contact between the teeth. So I must have a centric record very thick. And it is not so easy to do. That is first point on my right hand. On the left hand, it is complicated to correct my occlusal adjustment as this prematurity. There are some risk to do it for the teeth. It is very simple to do. There are no risk, no cost because the teeth has had a large restoration. It must be corrected. So I can realize an occlusal adjustment here very quickly, simply, and I do it in this condition. I think, it is my opinion, I think it is an obvious occlusal interference, and I correct it immediately before to make impression. Look at this patient. This is globally the same type of cases. It is an obvious decentering. ICP here and RCP here with a pre-contact prematurity here. By chance, I have a video. RCP and after go to the ICP. Yeah. If you look, when the patient he open normally and he go on right side to close to avoid the premature contact. Look at. This patient had myalgia on temporal masseter. I don't remember exactly. And just correction of this teeth by grinding in first part, in first phase, and concealing for auto control of the clenching. And the situation was clearly improved after. But in some case, it is not so easy. You could have obvious occlusal disorders like this because it is ICP of the patient. It is not in open phase. It is in the closing phase. Only contact on the last molar. He had muscular pain and cervical pain. Normal mandibular movement. You see the contact only on the third molar and anteropen bite for the other. Occlusal adjustment. Extraction of the third molar. Here we are. Initial, after extraction. Only contact here. He has two crowns, or two or three crowns, no, I don't remember, perhaps four, on the implant, which are recently realized. Grinding of the course of the crown here to obtain contact on the last part, on the lateral parts. Here it is the phase 3, and after bonding, I'm sorry, here, composite bonding here and here to stabilize the occlusion. With this simple treatment, the pain disappears because we reconditioning the muscular joint, your muscular play, and why we did this? Because we have a very strong, obvious occlusal disorders, which was easy to correct. If we are not really in confidence with this type of treatment, you can make an occlusal analysis, make a simulation of the articulator of the occlusal adjustment, and after do it on mouth. And we have a stable situation. 4 years, 15 years. It was funny because I don't see the patient from 10 years ago. And one time I saw on my schedule, I saw the name of the patient, but it's not the same name exactly. Okay? And the patient came to my office and he said to me, "Oh, I would like that you consult my boy because he has something. He has some click in the joint. All right. And I asked to him, and you, how are you? And he said, me, I'm well. And I say, how are your teeth? Oh, well, very well. I don't know. I have no teeth. Huh? And I take these pictures 50 years ago. So sometimes it is interesting to to play the card of occlusion in the game of TMD. But when you are very in situation very stable, in your brain stable, that that means you start from a very unstable situation, and so you increase easily by very few uh, tools the patient. You can see another. It is a patient, this young lady with an anterior open bite, with a tongue dysfunction and pain, bilateral pain, muscular pain, no problem with the joint. It is a muscular TMD. It is different. The teeth are health. All the teeth are health. Just aplasia of the lateral incisors. And she had an orthodontic treatment in the past, but with a relapse of the anterior open bite due to the tongue dysfunction. We treat it by rehabilitation, uh, I'm looking for the term in English, people which rehabilitate the function of the tongue, and orthosis, it is a lingual envelope, sleep lingual envelope. And after we can see, we need time. At this time, we make a small posterior, a small posterior occlusal adjustment, and compare this with this. Just rehabilitation. Another type of patient, articular TMD. It is a grade 3. You can see the condyle and the disc in open. Grade 3 of a left TMG. But complicated occlusion. Huh? And here it is difficult to take a decision. I have to, the first things I have to improve the patient, decrease the pain, and increase the capacity of movement by simple, non-invasive treatment, counseling, gymnotherapy. Before to put a splint. Sometimes it is enough because occlusal treatment in this case is not simple. and it is a difficult decision. So start the treatment by simple way, and after you say we have to see in 1 or 2 months what's happened, and after we can decide of other things. Don't remember that currently the physiotherapy approach is very efficient. Okay, invasive overtreatment versus invasive treatment. Invasive treatment is a characteristic of dentistry. When you treat something in dentistry, we make a hole into a teeth, we prepare the teeth, we bond something on the teeth, we move the teeth, we open the gingiva, and so on. You put an implant, you make a hole into the bone. Okay, dentistry is invasive. Always. So, it is not a problem for the dentist to make an invasive treatment. The problem for the dentist is to make an invasive treatment on a patient who does not need treatment. For the same clinical situation, for example, with the same Farah diagram, this patient with natural teeth, physiotherapy, reevaluation, and possible of post-splint. That is the therapeutic plane. For this physiotherapy, stabilization by adhesive dentistry, perio. For this physiotherapy, splint, and after prosthodontic treatment. So it depends of the dental status of the patient. In front of a patient with natural teeth, you will be very non-invasive. If we have something to do on the teeth to stabilize the function, you have to do in the first intention. And when you have to have prosthetic treatment to do, because because the status of the teeth, not because the TMD, you can make a temporary prosthodontic treatment and without splint. So we have two different situations. The patient who need dental treatment because the situation of the teeth, and the patient who don't need dental treatment. For the patient who don't need dental treatment, counseling, cognitive behavioral therapy, and physiotherapy, revelation, eventually occlusal splint, and it's enough. In other part Of course, counseling, cognitive therapy, physiotherapy are okay. And sometimes immediate occlusal correction if obvious occlusal disorder. Rarely occlusal spleen for me at this time because I can change the function by temporary or by bonding, composite bonding. And I prefer something like a tool, a tooth, a real tooth, than an acrylic on splint, which is a caricature of the function. And after, permanent rehabilitation. The problem and the difficulty for difficult cases is when a patient with natural teeth has a relapse. You make the treatment, he is going better, and up is coming back. You you restart for counseling, physiotherapy, oh, even splint is but and he relapse. He puts the splints, it's okay. He stop to wear the splint, he relapse. In this condition, you can ask for modification of natural health teeth. There is a lot of discussion in the literature about occlusion and TMD. But if you look behind the questions, what is the problem? The problem is it is a fight against, not against occlusion. It is a fight against overtreatment. And fight over against overtreatment is good fight. So I think we have not to correct occlusion of many patients with TMD. Just a simple way of treatment are frequently efficiency. But when you have to change occlusion for good reasons, in this case, when you change occlusion, we must be precise. Okay, I would like to go before stop. I would like to go to the obvious occlusal disorders. Just a minute. Sorry, because I forgot something. You remember this case with a strong prematurity on the second molar here. I said to you, it is an obvious occlusal disorders. Okay. For me, I define an obvious occlusal disorders. It is a strong occlusal disorders. Very easy to see. We don't need a microscope. Okay, very easy to see. Very easy to correct. It concerns one or two teeth, not 10 teeth. At this moment, these occlusal disorders must be corrected in first intention. Okay? But there are a risk. The risk is that the patient can think Oh, the doctor treat my my click or my pain or my cervical pain and so on, or my migraines by occlusal adjustment, and it is dangerous. You have to, when you do this type of treatment, you have to to give explanation to the patient before to grind the teeth and say to him, there is a problem on this teeth, but it is not the real cause of your problem, of your pain, of your migraine, of your tinnitus, and so on. It is because the teeth migrates, and it is there is a risk for the teeth. So I have to correct it before. Don't say to the patient the link between his problem to this obvious occlusal disorders. Why? Because to avoid to create occlusal dysesthesia. Because occlusal dysesthesia is the main problem that you could have in your office. It is the more complicated situation to treat. It is not occlusion which is complicated to treat. It is occlusal phobia, which is complicated to treat. Okay? So I finished. We can go for some questions about condylography. There is question, do we need condylography in all cases? My answer is clear, it's not. In case of we have two situations: TMD cases and prosthetic cases. From the TMD cases, the diagnosis is clinical examination and panoramic radiograph. You must have a clear diagnosis, and we have clear diagnosis in perhaps 80% of the patient. For the other, and for temporomandibular, for joint TMD, uh, condylography is a good indication to precise the diagnosis. And after, if the diagnosis is not so clear, MRI could be, or scanner, CBT, can be improved the diagnosis. In TMD case, so it is to precise the diagnosis when it is imprecise. Other indication for condylography in TMD case could be repositioning splint. If for any reason we say I want not to, I have to do not a classical splint but a repositioning splint, I need to adjust correctly the articulator. And for prosthetic cases, I use condylography to, so prosthetic cases without TMD, with a normal joint, I use condylography for extensive treatment, and sometimes only for the anterior rehabilitation, to have a concordance between anterior guidance, and sagittal condylar inclination. Other questions? No questions? No more questions? Questions for you keep questions for tomorrow. So you have to digest this afternoon and also the Saturday day. I believe that it is not a binary problem. It is not because you put out the premolars that you induce necessary a TMD. It depends on many factors. And first, it is we have to go back to the basic knowledge, occlusal function, stability. First, the first molar. If the quality of the first molar are very good, the occlusion on the first molar is very good. If you have one or two premolars, it's not real of the questions. Also, we can have a occlusal function with one or with two premolars by sector. But we have to organize it, to organize the occlusion correctly. Stabilizing, centering, guiding. I use sometimes equalizer in emergency case. When I have no time, there is a patient with a strong pain on a joint, with a capsulitis, and I give to the patient one equalizer, and I said to him, come back tomorrow, and so on. Just emergency. Other questions? Hey, come on, give me two questions. I don't leave until I have two questions. Okay, one question. It's not an easy case. Sometimes I show you Saturday the possibility for treatment in anteposition, in a protrusive position. And in this case, when you are in class 2-2, you can little bit by automatic way open the guidance and create an anteposition by prosthetic reconstruction posteriorly. I need more. I need one question more until I leave. Okay, for the class 2-2. And in the class 2-2, it is difficult to make an anterior repositioning without correction of the anterior teeth. No more questions? Yes, I'm sure you have a question. Do you want the file of thank you. Yeah, it's a good question. The difficult questions because uh, when I speak Saturday on the architectural criteria for occlusion, I don't speak about asymmetric case. And asymmetric cases are difficult. And we have to think in two different ways. Because we have to think asymmetric, frequently you have asymmetric of sagittal condylar inclination. You have asymmetry of occlusal spleen and also asymmetry of radius of curve spleen and asymmetry of the guidance. And the goal is to symmetrize the function, especially mastication. To obtain symmetric mastication on the right and on the left side with asymmetric structures, we have to adjust the causal plane, guidance, and cusp height to obtain the same disclusion angle on the lateral part. If you have the same disclusion angle, the same disclusion space on the right side and on the left side, you induce the possibility to chew on the right or on the left side with the same efficiency. But it is not easy to do and impossible to describe in 5 minutes. But do you understood my way of thinking? And we can ask a question concerning if you are interested by this, by the concept of planas with a masticatory angle. We can discuss it tomorrow. Okay? The big chief, Juliana. You close the session? Okay. Tomorrow we discuss planas. And I'm looking for the form with a tool to assess the movement. Okay. See you tomorrow, 8 o'clock Moscow time. I am correct?